So even if we start, he can just join, right?
We are live.
Okay.
Hello, welcome to the NephJC Google Hangout. My name is Joel Toff, and I'm going to be helping us go through the Simplicity trial. The Nephrology Journal Club, Twitter Journal Club, is an open access international online journal club where we discuss some of the most important literature in nephrology. We've got a great panel here to talk about the Simplicity 3 trial. We have my cohort, Swapnil Harmat. We've got Matt Sparks from Duke. We've got John Mandela, and then we've got study author George Bakris. To start off this talk, I want to have Matt. Actually, first of all, I want to advise everybody, please sign up for our mailing list, get notifications of all these events that we do. The mailing list is limited in volume. You're only going to be getting about one email a week. So, Matt, why don't you start us off and tell us a little bit about the science behind renal denervation?
Hi, everybody. I'm Matt Sparks. I'm a physician scientist at Duke University and the Durham VA Medical Center in Durham, North Carolina. And I'm going to talk a little bit about the background of how this came to be. First off, the development of catheter-based renal denervation was based on several assumptions. First off, excessive activation of the sympathetic nervous system to the kidney potentially plays a major role in the pathogenesis of hypertension, and in this study's case, resistant hypertension. And what this study really boiled down to is if disruption of the nerve fibers located in the adventitia of the renal arteries would lead to inhibition of the efferent pathway or the sympathetic tone to the kidney, and that you would have benefit by decreasing salt and water retention and also renin release. So decreased renin release, which would all in part decrease blood pressure. So these were sort of the ideas behind renal denervation. There's also other ideas. For instance, disrupting the afferent pathway could also play a role in both cardiac hypertrophy and vascular remodeling. And we'll probably discuss later that our current trials ongoing looking at renal denervation in heart failure.
Excellent. Sorry about that. Swapnil, can you tell us a little bit about what the state of the science was leading up to Simplicity Hypertension 3?
Yeah, thanks. I'm Swapnil Harmat. I'm a co-editor and co-founder of the NephJC Club, and thanks everyone for joining in. So as Matt said, there was all this basic science data suggesting that the renal denervation may perhaps work in treatment of hypertension, and there is a role for increased sympathetic hyperactivity in hypertension. So in 2009, most of the initial work has been done by Marcus Schleich, Murray Esler, and others from Australia. They had this one case where they did they ablated the renal afferents and maybe even the efferents in the renal arteries. These nerves which are present in the adventitia of the renal arteries underwent radioablation, and they had this single case report initially which came out in the New England Journal showing a dramatic drop in blood pressure. This was followed by their proof of concept Simplicity 1 trial, which had about 45 patients. And again, these were no controls. These were before and after renal sympathetic denervation, and there was this dramatic drop of about initially of about 15 to 20 millimeters, but at 6 months of about 32 millimeters in office systolic blood pressure. This was again before and after in office systolic blood pressure. This was followed by the Simplicity 2 hypertension trial, which was published a few years later. This was a trial with control. So, you could argue that Simplicity 1 was just before and after. Simplicity 2 did have controls who did not undergo renal sympathetic denervation. And there was no change in blood pressure in the control arm, but in the patients who underwent renal sympathetic denervation, there was again this dramatic drop in blood pressure, office systolic blood pressure of about 30 millimeters of mercury. And again, at this point with Simplicity 2, there was this randomized controlled trial which had controls, but they were open label. And everyone was very keen that we should just go ahead. This seemed like a dramatic, fantastic innovation for patients with resistant hypertension. And it led to Simplicity 3. And at that time, there was so much optimism. We've talked about it on Twitter and on blogs about this being the next breakthrough. So it was interesting that Simplicity 3 had this rigorous study design. And I would like Dr. Bacchus to talk about some of these aspects. In hindsight, these are all very astute stuff that was done, but Simplicity 2 was so impressive that I'm interested to hear his thoughts.
Well, one of the interesting things is that was enough information for Europeans in a lot of different places. They're using renal denervation as a standard therapy for hypertension now.
Mm-hmm. Mm-hmm. Indeed. At the recent EuroPCR, there was a great discussion about that too. But let's leave that for later.
Hey, Dr. Bacchus, can you tell us a little bit about Hypertension 3 or Simplicity 3?
Sure. So the major issue with Simplicity 3 was there was a huge deficit in terms of good scientific design. There was no placebo control. Nobody really excluded resistant hypertension as a true exclusionary diagnosis. White coat hypertension was not excluded. So there were a number of possibilities and problems that needed to be dealt with when dealing with the study design. So the main issue was really how can we come up with a study design that the FDA will buy, that has good scientific rigor, that will either confirm or not confirm the previous data that existed, and basically really answer the question definitively, is there in fact a benefit from renal denervation if you do everything right? So the protocol was powered for the primary endpoint of office systolic blood pressure, which was actually what the data were in the previous trials. But one of the things I wanted to do, the company was hesitant, the FDA liked the idea, is to power it for change in ambulatory blood pressure of systolic blood pressure. They didn't have the power to do that, so it became a pre-specified secondary endpoint. The bottom line was that...
George, why would that take more... Why would you need a larger cohort to get ambulatory blood pressure, power for ambulatory than for office?
No. Actually, for ambulatory, you would have needed less. But the primary endpoint was office BP. Ambulatory was a pre-specified secondary endpoint. And so, in fact, they were kind of overpowered for ambulatory, but they were really powering for office BP change. So that was really the primary deal. Moreover, I mandated that everybody had to be on appropriate blood pressure therapy coming in. That was not done in the previous trials. You had to be on a diuretic, a real diuretic for your level of kidney function, a real ACE or an ARB at maximal dose, and a real CCB. And that is what all the guidelines say, and that had to be the case. Now, that wasn't good enough. If you thought Spiro was appropriate, you could have used Spiro. We encouraged that. But many of the people, in fact, the trial was on an average, everybody was on an average of 5.2 drugs. And so clearly, this was it. White coat hypertension was the #1 reason for screen failure. 62% of the people coming in screened failed because of white coat hypertension. You had to meet the office and you had to meet the ambulatory ABPM. And the ambulatory BPM, well, it was a low bar, greater than 135/85, which is simply hypertension. It's not resistant hypertension. So you needed all that. Then you had to meet, if you were going into the cath lab and you meet all that, you had to show that you were adherent with medications at home, with home blood pressure monitoring and drug diaries of when you were taking your medications. And then if you met all that, then you went into the cath lab, and if your renal artery did not have specific dimensions and characteristics, you were still excluded. So this is a very, very strict protocol, very select group. Many in Europe accused me of having too strict a protocol and therefore bet against this. But if this was really meaningful, then we should have gotten the results similar to what they got in the previous trials. And because we got rid of all the confounding with white coat hypertension and really selecting out people on appropriate therapy, there was a blunted response. And so that was really the goal. Now, the 24-hour ABPM data, I know we're talking about the New England paper tonight, but the 24-hour ABPM data is published online in JACC, and I just presented that as a late breaker at the American Society of Hypertension.
Could you give a quick summary of what that paper looks like? Is that meaningfully different than what we just read in NEJM?
No, it's actually more. It's actually more indicting. The 24-hour ABPM data, you saw that in New England, so no difference in the systolic. The diastolic pressures, there was only a millimeter difference. The 24-hour, the daytime blood pressures, absolutely no difference. There was a difference in nighttime blood pressures. The systolic blood pressure actually was lower in the denervation group, but it just missed statistical significance. The diastolic blood pressure also trended in the way that P was 0.06. Did it convert people from dipping to non-dipping, or non-dipping to dipping? And the answer is there was a trend, but it was not significant. So blood pressure variability, did it improve with renal denervation? No, it did not. So the bottom line is it was confirmatory of what you saw in the New England paper.
So George, I think though technically there was equipoise on this question, I think the world really was expecting this to be the next great therapy. And just how does it feel when that data finally gets unmasked and you're the only person in the world that knows that this stuff don't work?
Well, we were getting ready for a revolution because we figured that at least interventional cardiologists, we would be on their hit list because we were taking away something that they firmly believed in. And then we were really stuck scientifically with trying to figure out either A, this stuff doesn't work at all, because, by the way, there was no benefit on glucose. There was no benefit on other things that we had looked at that had been shown before. So it was really very disheartening. So the question is, was there something in the protocol that precluded this? Is the effect really that small? Or was the procedure actually done correctly? I, as a nephrologist, would have never imagined the procedure would not have been done effectively. But I will tell you, compared to the European sites that got a lot more experience prior to the study, the U.S. sites, many of them had only done a couple of procedures prior to actually getting in the study. And
George,
there is
we've got kind of a ringer here. John, Dr. Mandela is an electrophysiologist.
Okay.
Can you give us a little bit of color on the technique of this entails?
Hey everybody, thanks for having me. Can you hear me okay?
Yeah.
You sound great.
Yeah, so I think Joel has overestimated my expertise in ablation in the kidney. It's actually I'm not sure how similar it is in the kidney, but the biggest concern that most electrophysiologists have about this procedure is whether what they were burning and what was being accomplished and what the endpoints were. In the EP lab, we have these markers. We can see the electrogram at the tip of the catheter go down. We can see that the arrhythmia is no longer inducible. And when I wrote this post on theheart.org about the lessons learned, a kidney ablator called me up and said that the biggest problem with this was the procedure and that the lack of endpoints. So I don't have the answers, but I think it's a major concern. At least I hope you all agree that is.
Yeah, I mean, this was one of the things that a lot of the critics of the study pointed out was the fact that there might have been some technical problems with that. George, do you have any color on that?
Yeah, I was just going to add to that there's two major issues. Number one, unlike another related procedure, the baroreceptor activation therapy, where you know exactly what you're doing because you can literally turn the magnet on and off. It's like a pacemaker, and you can see heart rate changes, blood pressure changes immediately. Here, you really don't know if you've done a good job or not. You don't have norepinephrine spillover. You don't have muscle sympathetic nerve activity to look at to see if you've really done the job. Moreover, the nerve anatomy of the afferents and efferents in the renal artery is not so obvious. People are assuming certain things, but if you carefully look at it and dissect it out, they have different patterns. It's like a road map. And coming in, from the aorta, the afferents actually are very, very exterior, and as you approach the hilum, they get deeper. And the efferents are the opposite. They start out in the periphery, and as you approach the aorta, they actually get deeper. So if you're burning indiscriminately, you may or may not be successful. But it's pretty clear when you look at some of the data, and this isn't published yet, but let's just say that the more burns you did in a variety of locations, the greater the effect was. Now, the electrophysiologists, I'm sure, are not surprised by that. And certainly the Germans were not surprised by that when they saw their data. And again, hopefully that data will be published, but they're actually trying to validate this now internally and relate to the anatomy of the burns and the actual blood pressure reducing effect. But grossly looking at it, there definitely is a trend, and not every center did it exactly the same way, so there's some standard deviation in the procedure itself. So, you know, just to put my 2 cents in, because you probably are going to ask me, do I think this area is dead? I think the answer is no. I think the answer is alive and well, and this is actually a pause for understanding the basic science better before we move forward.
So some of the other issues that were raised about simplicity was, one, do the use of aldosterone antagonists ablate some of the effect? Does anybody have some thoughts on that?
Well, let me just tell you, we specifically looked at that. The people that got into the study, there were about 25% of the people that were on aldosterone antagonists and still met the criteria for resistant hypertension. Spironolactone is not the end-all be-all. There's a paper just published in the Journal of the American Society of Hypertension that actually looks at different genotypes. And actually, if you have a certain genotype, which about a quarter of the people have, that predicts spiro failure in terms of blood pressure reduction. So, because the aldosterone effect is minimized. So I think that we truly had the spiro-resistant patients. I will tell you the second most common reason for dropouts was use of spironolactone. So this is very important. There's also some very interesting data in the African American subset that I'm not at liberty to discuss, but let's just say that this is not all about the renin-angiotensin system or the sympathetic nervous system. I think we have to include our friend nitric oxide in the mix because that's a player as well.
Yeah, it's funny that you bring up African Americans. That's the very next thing on my hit list here was that that was brought up as being a potential difference between the American study and the European experience, which they're very positive about. Matt, Swapnil, do you guys have anything to add that we haven't talked about here?
Yeah, so if I can add a couple of cents, even if we accept that the effect in the renal denervation arm was a bit attenuated because of technical issues or African Americans, what was most fascinating about the Simplicity 3 trial was the effect seen in the control arm of between 10 and 15 millimeters of mercury compared to Simplicity 2 where there was a 0 millimeter decrease in blood pressure. So that suggests that the true effect of denervation, even if it is minus 25 or minus 30, compared to the placebo arm of about minus 12 or 13, the true effect of renal denervation is not going to be minus 30. It's perhaps on the order of minus 10 in office systolic blood pressure, and it may be even less in the ambulatory blood pressure. Would that be an accurate statement to make?
I think it is definitely accurate. In fact, I predicted that the difference between the two would be about 6 to 7 millimeters. We predicted 5. We got just shy of 3. But if you actually look at the basic science data, if you go to Jerry DeBona's data or look at some of the other animal data on denervation, the blood pressure effect is 10 millimeters, 12 millimeters. It's not really drama. So I think it's important to keep in mind that the renal nerves are not the end-all be-all either, and if you've done everything well, they're only going to contribute a limited amount. So I think that's a very important point.
One thing that we in social media, there's a lot of static about bad actors, pharma companies behaving poorly. And from where I sit, reading the Simplicity trial, it looks like it was carried out with tremendous integrity. Can you provide any color on how Medtronic was to work with?
Let me tell you, they were phenomenal. I've worked with a lot of pharma companies in my life, and Medtronic was above board, honest. The data are the data. It should speak for itself. We need to learn from them. They were absolutely superb, pristine. I can't say enough positive things about them. They were just great.
And actually, that also brings up something. Any comments on the difference? You know, especially as nephrologists, we have so little information or experience dealing with procedures and devices. You know, in what ways is it different than the more common drug therapy that we're used to evaluating?
Well, here there's actually, I mean, drug therapy. One of the big issues, and this was brought up earlier. One of the reasons that the placebo arm was thought to have been doing so well was, in fact, that we mandated these people take their drugs. They were being followed very closely. They knew that if they didn't follow the rules, it was penalty of death, practically. So I think adherence to medications played a major role here. There's two seminal trials that were just published in real-world practices that showed that at best adherence in the real world, and one was in Germany, one was in the UK, is 45%. So only 45% of the patients actually take their meds. If you imagine a clinical trial now where everybody's taking their meds, wow, it's amazing. So, you know, that's a major factor. But I think compared to a drug trial where there's blinding and you have the adherence issues, here it's a procedure. So theoretically, there shouldn't need to be any adherence issues, because if the procedure is doing something, you'll see it independent of what the patient is doing. And of course, if they're taking their meds, that's going to blunt the effect. And that has been the assertion of our European colleagues, is these patients were following the rules, so that's why you didn't get an effect. And my comeback to that is, well, okay, if that's true, then this isn't doing much, and so why should the government pay for it? So it's a stalemate.
Yeah, thank you, George. This has been excellent. I think it's been a great discussion on simplicity. I just kind of want to go through the panel and get kind of final thoughts on simplicity. You know, I want to lead off, and to me, this gives such a great demonstration of the importance of a well-designed, well-controlled clinical trial, where something that can look so powerful and so magical, it can just fall away when you do the right study. I think it's a really impressive demonstration of the scientific method. Swapnil?
Yeah, exactly. I would like to congratulate Dr. Bakris and the Simplicity 3 investigators. I think this was a fantastic trial. The use of the study design was extremely rigorous, the use of sham controls and all those things. In terms of going forward, I think it would be necessary to still do some mechanistic studies. Yes, these are the technical aspects, but I find it hard to believe that the phenotype of resistant hypertension is all due to sympathetic hyperactivity. You know, so if there was any way to identify those patients who would potentially respond, either by doing norepinephrine spillover, whole body or renal, or perhaps muscle sympathetic nerve activity, and only do it in patients who have high levels of these, would perhaps be a next step. Matt?
Yeah, I just want to reiterate a few things that George and I think John also mentioned. I think it's important that we, before we jump into clinical trials like this, really understand the basic science of what has actually happened, get biomarkers to understand if, you know, if we're actually ablating anything. And maybe this is an example of rushing to the patient before we really knew what we were doing. And then try to identify the patient population that have sympathetic overload to the kidney and somehow identify that group. I don't know if this is dead. I'd like to see this looked at again, but it might be a while before that happens. Congratulate George for a great trial, and as we've talked about on social media, myself, Swapnil, and Joel, we're really waiting for these results. So thank you.
John?
Yeah, thanks for having me. I've learned a ton from this, and the two things I'd reiterate are the sympathetic overload issue. I do think there are a select group of patients out there who are hypercatecholamine that I actually think about in my AFib ablation population. I think, man, this would be interesting to do renal denervation in this patient. So I think that there is a population of patients out there, but I also, as an electrophysiologist, I just can't get past the idea of knowing what we're ablating and measuring something, be it biomarkers or something. So anyways, thank you for having me, and it's been great.
Joel, let me make one final comment.
Please.
To John's point, I will tell you, in the patients at least that I recruited for the study, these are patients that were on an average of 7 to 8 drugs, and I will tell you that included reserpine, beta blockade, clonidine. Okay, so I'm sure John would say that if you did that, that's a guaranteed pacemaker right there. Reserpine, clonidine, and beta blockade. And these people, okay, on good doses of those drugs, had heart rates in the high 80s, low 90s. Their baseline was like 110. So there is a subgroup that definitely is identified, and Steve Julius has published a lot of data on this in terms of heart rate and sympathetic tone and hypertension. But there's clearly something off with their, at least either their vagus or their modulation of their heart rate, and I don't know what that is, but we could not control it. And the first hint I thought that something was wrong was not looking at the blood pressure, but after denervation, I did not see changes in heart rate, and that to me signaled a problem. So that's just a final comment.
Excellent, excellent. Thank you, guys. This has been a great discussion. I want to take this moment right now to introduce the paper for next Tuesday's NephJC. We're going to be talking about the recently released clinical practice guidelines on diagnosis and treatment of hyponatremia. These were put out by the European, or published in the European Journal of Endocrinology, but it's a collaborative guideline put together by the European Society of Intensive Care Medicine, European Renal Association, European Dialysis and Transplant Association, and the European Society of Endocrinology. They are very interesting guidelines. I think this is an area that nephrology is going to see a lot more of. We're used to guidelines on hypertension and dialysis, and we're just starting to see electrolyte disorders joining the club there. I think the guidelines on acute hyponatremia are really sharp and really oriented towards treatment, and they're easy to follow, and I think they are pretty logical. I think their treatments on chronic hyponatremia and asymptomatic are kind of out there, and I think it's going to stimulate some pretty interesting discussion. You can look for an introduction and background material on NephJC.com by the end of the week. Everybody's got to get their Kidney Week posters done and abstracts in on by the 5th, so I don't think we'll have it done before then. But I'd like to thank all my panelists, and I will see you guys on Twitter next week. Thank you, guys.
Thank you.
Thank you.
Thank you.
Thanks, Joel.
Thanks, you.